Ladies and gentlemen, thank you for standing by. Welcome to the CHRS Ablation of Atrial Fibrillation Pathophysiology webinar. During the presentation, all participants will be in a listen-only mode. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Thursday, April 24th, 2014. I would now like to turn the conference over to Deborah Campbell. Please go ahead.
Thank you. I'd like to welcome everyone. For those who do not know me, my name is Deborah Campbell, and I am your new Allied Health Professional Representative for the Canadian Heart Rhythm Society. This evening will be our first webinar for 2014. And I want to thank Marie-Andre, Jason, and Lauren for all their hard work and dedication to ensure the webinars continue for the Allied Health Professional Group. Webinars provide an opportunity to learn from the experts in our field in the comfort of our own home and, depending on your time zone, possibly your office and conference room. Many of us, including myself, are feeling the impact of fiscal restraint, which has limited our ability to attend conferences and meet our ongoing learning needs. Through your membership, webinars are a huge benefit, so I hope you will share what you have learned tonight with your professional colleagues and encourage them to join the Canadian Heart Rhythm Society Allied Health Group. I am truly honored this evening to have the opportunity to introduce Dr. Clarence Khoo. Dr. Khoo is the most recent addition to the electrophysiology group at St. Boniface Hospital in Winnipeg and is an associate professor with the University of Manitoba. He completed his internal medicine training at the University of Toronto in 2008 and went on to the University of British Columbia, where he completed his cardiology training in 2011. He continued at the University of British Columbia, where he completed a 2-year fellowship in electrophysiology at St. Paul's Hospital. Dr. Khoo's research interests include the management of atrial fibrillation, syncope, and devices. On behalf of the Allied professional members and the Educational Committee for the Heart Rhythm Society, we want to thank you for taking the time to share your knowledge and expertise with us this evening. The title of Dr. Khoo's presentation is Ablation of Atrial Fibrillation, Pathophysiology, Principles, and Potential Future Avenues.
Great. Thanks, Deborah.
You're welcome.
Good evening.
Thank you.
Great. Thank you. Good evening to everyone, and thank you for having me speak with you today. So today I've decided to speak to all of you about a condition and a procedure that most of us have dealt with and encountered on at least some capacity, and that is the ablation of atrial fibrillation. Through this talk, I hope to provide some insights with regards to why atrial fibrillation ablation is performed the way that it's performed today. By the end of this talk, I will hopefully be able to cover these objectives. I would like for you to understand the current hypotheses underlying the initiation and propagation of atrial fibrillation, as well as to appreciate the rationale for existing techniques of atrial fibrillation ablation. Moreover, I also hope to explore the role of differing methods of energy delivery in atrial fibrillation ablation and to potentially touch on some of the controversies and potential future directions with the ablation of atrial fibrillation itself as well. So on this slide is captured the entirety of atrial fibrillation ablation, which is currently supported by the CCC guidelines. And amongst it are facets of care that most of us are familiar with, including anticoagulation of the patient, but moreover also management of the arrhythmia itself. And amongst the two major strategies for managing atrial fibrillation are both the control of the rate as well as control of the underlying rhythm. And when it comes to the actual management of the underlying rhythm, catheter ablation or ablation of atrial fibrillation is a prominent modality that is included alongside that of pharmacotherapy, which is the use of antiarrhythmic therapy. Before we actually talk any further about atrial fibrillation ablation, I was hoping to actually speak first about the anatomy of the atria. And by reviewing some of the anatomy of the atria, hopefully we'll be able to understand a little bit more about the subtleties of atrial fibrillation ablation and some of the complexities that arise during the procedures themselves. So this is a view of the left atrium, taken from a slightly superior and a slightly posterior view of the heart. What we can see is that the posterior wall of the heart is actually not just posterior, but also slightly more cephalad or superior to the heart itself as well. Now, the actual thickness of the atrial wall can vary quite a bit depending on where on the atrium it is. On average, it's about 3 millimeters thick, but it can range from anywhere from 1.5 millimeters to as thick as 6.5 millimeters. And it's thick and often at the roof, which is at the superior aspects that join the left and right superior veins, as well as the inferior aspect of the posterior wall. Now, as we can see here, the 4 pulmonary veins, the left superior, the left inferior, the right superior, and the right inferior pulmonary veins, enter into the posterior aspect of the left atrium itself. What is also important to note as well is the proximity of these veins to some of the other cardiac structures. Here, for example, is the left atrial appendage. And this, as we can see, is actually extremely close to the left superior pulmonary vein. And this becomes of importance when we're doing atrial fibrillation ablation procedures, because sometimes we can actually see what are actually far-field left atrial appendage electrograms within the LSPV itself. Similarly, there is an extremely close proximity of the superior vena cava, the SVC, to the right superior pulmonary vein as well. And that explains why sometimes we can actually see electrograms that actually arise from the superior vena cava within the right superior pulmonary vein and vice versa. Looking at the left atrium from a more left lateral view, we again sort of reinforce the same close proximity of these veins to other structures. Left atrial appendage again is extremely close and almost abuts the left superior pulmonary vein, and is separated by a narrow ridge here, which we will see on a separate slide as well. Also of note here, we can see that the esophagus actually runs extremely close to the posterior wall of the left atrium, and thus is prone to injury with ablation of the left atrium posterior wall. As promised, here is that ridge that we were mentioning a little bit earlier. So this is the lateral ridge. So this is looking at the left atrium from within the left atrium itself, and looking towards the left superior and inferior pulmonary veins. The LSPV is up here, and the LIPV is down here. This is the inside the left atrial appendage, and what we can see is this narrow ridge here that separates the left atrial appendage and the left superior and left inferior pulmonary veins. As you can see, this is a fairly narrow structure without very much purchase for a catheter. And as ablation is performed down here on the anterior aspect of the left-sided veins, this area is was notorious for being extremely difficult to maintain adequate catheter stability. On the other side, so on the exterior or external side of this lateral ridge, is this structure here, which is the vein of Marshall, the ligament of Marshall. And this is the remnant of the left side SVC that occurs during embryogenesis. And in some individuals, the vein of Marshall, the ligament of Marshall, may also contain certain triggers, and we'll get back to triggers a little bit later, which can actually initiate atrial fibrillation. And as we can see here, this actually runs in the outer aspect or the exterior aspect of this lateral ridge between the left atrial appendage and the left superior pulmonary vein. And thus, when you ablate in this area, you not only are ablating potentials within the actual atrial wall of the left lateral ridge, but you may also be actually impacting triggers within the vein or ligament of Marshall itself as well. Now, those of us who have spent a lot of time dealing with the anatomy of a left atrium will know as well that there are a number of variants of pulmonary vein architecture and anatomy as well. And one of the more common variants that we see is the prevalence of what are known as common ostia. So on the left here, especially in the left upper image, we are seeing basically a cross-section of the 4 pulmonary veins. And what is most normally seen are the 4 pulmonary veins come in almost as separate entities within the actual left atrium itself. once in a while you may actually see two veins that come and form almost a common conduit before the common conduit then joins the left atrium, and this is known as a common ostium. Looking at the veins from the inside of the atrium, we see the same difference here. On the left are two separate ostia, whereas on the right there is almost a common ostia that the two veins join into before it actually joins into the left atrium itself. And as you can imagine, this can pose certain technical difficulties when trying to achieve isolation around some of these veins, especially when you're trying to use an occlusive device such as a cryoballoon, because it may pose some technical difficulties to actually achieve complete occlusion of such a large orifice. Now, common ostium is present in about 25% of individuals and is most common on the left side versus the right side. In addition, another anatomical variant that can be seen is a separate right middle vein that drains from the right middle lobe of the lung. And this can also be seen in about a quarter of individuals. The last anatomical thing I want to bring up is, again, to remind individuals about the proximity of the left atrium to other structures that are extracardiac. This is a view of the left atrium from behind, so the posterior aspect. And as we can see here, the esophagus abuts the posterior wall again, very close to the posterior wall of the left atrium. And thus the left atrium, when ablated at the posterior wall, can cause injury to the esophagus. Similarly, this is looking at the heart from the right side. The right phrenic vein runs extremely close to the anterior aspect of the right superior pulmonary vein, and thus may also be prone to injury with ablation around the vein itself. So these are all structures that have to be that individuals have to be worried about when performing ablation in and around the atrium. Now that we're all familiar with the anatomy and the stage upon which atrial fibrillation plays, we should probably start discussing why atrial fibrillation actually occurs and whether or not this knowledge can aid in our ability to ablate this condition. Just to back things up a little bit, I think most of us are familiar with the different classification of atrial fibrillation. And atrial fibrillation progresses, or can progress with time, from paroxysmal atrial fibrillation, which is an entity that either spontaneously terminates within 7 days or is cardioverted within 48 hours, to longer-lasting variants of atrial fibrillation. Persistent atrial fibrillation lasts for greater than 7 days or is cardioverted after a 48-hour period, and this can progress to long-standing persistent atrial fibrillation, where atrial fibrillation is present for more than 12 months. In individuals where there is no desire or it's decided that atrial fibrillation is not going to be managed with a rhythm control strategy, at that point it is considered to be permanent atrial fibrillation. Now, at the present time, the exact mechanism as to why atrial fibrillation occurs remains somewhat uncertain, but there are a number of hypotheses out there that seek to explain why atrial fibrillation occurs in individuals. And the current concepts that are suggested involve a few factors. Atrial fibrillation likely involves a trigger, so something that actually initiates atrial fibrillation itself. But above and beyond that, and in certain individuals, there also needs to be an ability for the atrial fibrillation to actually sustain and propagate. And this requires a number of potential things, including an appropriate substrate or an appropriate stage for which atrial fibrillation can dance its grotesque dance, and possibly also certain propagating factors such as focal drivers and rotors, which I'll touch upon in a short period of time. It can be argued that the current era of atrial fibrillation ablation occurred in about 1998, and that was when a fairly seminal article was published that identified the presence of triggers of atrial fibrillation that occur deep within the pulmonary veins. And in this publication, it was shown that ablation of these foci was also able to eliminate atrial fibrillation at a mean of about 7 months of follow-up in 62% of individuals who underwent ablation of these triggers. Now, triggers of atrial fibrillation may not necessarily need to be within pulmonary vein itself. Other ectopic atrial activity or focal tachycardia can also induce atrial fibrillation. And aside from the pulmonary veins, these triggers can arise from foci such as the superior vena cava, the coronary sinus, or the ligament of Marshall. And these are all structures that we looked upon earlier. These triggers are hypothesized to essentially enter into the atrial mass, and as it encounters areas of heterogeneous refractory tissue, produce reentrant wavelets that thus form atrial fibrillation. In some individuals, these triggers serve only to initiate atrial fibrillation, whereas in others, they may also help to propagate atrial fibrillation. And thus, individuals with the latter class of triggers, ablation of these triggers may actually not only prevent atrial fibrillation from occurring, but may also terminate atrial fibrillation in progress, whereas the former is more likely to simply prevent further initiation of more atrial fibrillation. Atrial fibrillation occurs when you have triggers because when you have a trigger that is firing faster than the refractory period of surrounding tissues, it is unable to conduct one-to-one to the surrounding tissues. And thus different parts of the tissue surrounding the trigger may then be activated with different cycle lengths. And as a result, a fairly haphazard propagation occurs around it, thus resulting in fibrillation. As we noted earlier, not just pulmonary vein foci, but other focal rhythms or even atrial supraventricular tachycardias can actually serve as a trigger for atrial fibrillation. And this is, for example, one case where an accessory pathway-mediated reentrant rhythm was able to induce atrial fibrillation. And not only are conditions such as AVRT able to induce atrial fibrillation, but also atrial flutter can sometimes degenerate to atrial fibrillation itself. And thus, there is a possibility that ablation of these other arrhythmias, an SVT or an atrial flutter, may also then reduce the risk of further atrial fibrillation in these individuals. So as we saw earlier, pulmonary veins were shown to be a potential source of trigger in a lot of individuals with atrial fibrillation. And one may ask, why are pulmonary veins potential triggers? And the reason this is because pulmonary veins actually share the same embryologic origin as other conductive tissues, such as the atrial muscle. And it has been shown that atrial muscle actually extends in a sleeve-like fashion within the veins itself. So stained in red here are atrial muscle cells, and we can see, at least in these slides here, that this extends within the pulmonary veins themselves as sleeves. And these tissues have been shown to actually have the potential of firing either spontaneously. Some of these have, for example, the ability to depolarize in phase 4 and thus have spontaneous, almost pacemaker-like activity and thus fire spontaneously. They may also exhibit triggered activity, and this has been shown, for example, in individuals provided with digitalis. And there's a possibility as well that in these individuals there may even be micro-reentry within the pulmonary veins that thus set up the potential for pulmonary vein triggers. The autonomic nervous system also plays a role in pulmonary vein firing. The provision of medications such as isoproterenol, which increases beta-1 stimulation, can increase the firing of pulmonary vein triggers. In addition, there are clusters of autonomic plexi. So these are areas of nervous input into the actual cell, into the actual heart itself, that can contribute to arrhythmogenesis as well. And stimulation of the autonomic nervous system through these ganglionic plexi can produce firing of these pulmonary veins, thus initiating atrial fibrillation. And there are certain techniques of atrial fibrillation ablation that attempt to target these ganglionated plexi and ablate them. And it's been shown that in certain individuals, at least modification of these GPs can actually eliminate firing of the pulmonary veins. Now that we have talked about triggers as a potential cause for atrial fibrillation, I'd like to shift and talk about the atrium itself as a substrate for propagating atrial fibrillation. Now, atrial tissue that has a number of heterogeneous refractory periods is more likely to sustain atrial fibrillation. And in fact, in individuals who have idiopathic atrial fibrillation, this increased heterogeneity has indeed been established. As individuals age as well, fibrosis of the atrium can occur, and this can result in increased heterogeneity of the underlying tissue as well as developing areas of slow conduction and areas of conduction block, thus allowing for re-entry within the atrium itself and thus also propagating atrial fibrillation. A number of conditions that have been associated with atrial fibrillation has also been shown to alter the substrate of the atrium itself as well. Conditions such as heart failure, diastolic dysfunction, valvular heart disease, sleep apnea, or even endurance exercise may result in alterations of both ion channel function as well as remodel the atrium itself, and thus again leads to heterogeneity in conduction. And last but not least, there is the credo that atrial fibrillation begets atrial fibrillation, and there have been studies that have shown that long-standing atrial fibrillation can also result in ion channel and atrial remodeling, thus again altering the substrate itself and helping to sustain further atrial fibrillation. One of the oldest hypotheses behind why the atrium itself can propagate or sustain atrial fibrillation is the multiple wavelet hypothesis. And this posits that atrial fibrillation is sustained by multiple wandering wavelets of activity that collide with areas of refractory atrial tissue with other wavelets. And these wavelets then break up and cause other daughter wavelets that continue to re-excite the atrium. And the computer models that initially looked at this suggested that there were probably at least 4 or 5 different wavelets occurring at the same time within the atrium. And if one had more wavelets, it was harder and harder than to expect that all these wavelets would extinguish at any one time. And thus, the more wavelets there are, the more likely the atrial fibrillation is to sustain. And thus, a large enough atrial mass is then required to be able to sustain all these wavelets. And which is not surprising then why we sometimes see extremely large atria in individuals with long-standing or permanent atrial fibrillation. Unlike the seeming chaos and randomness of the multiple wavelet hypothesis, a more recent hypothesis that has been gaining a lot of traction has been that of the localized source hypothesis that posits that there is potentially some method behind the madness of atrial fibrillation. And instead of there just being random wavelets that meander around the atrium, there is a belief then that there are potentially a few stable reentrant circuits in the atrium that act as a focus, and these are believed to be mother circuits, or as we'll soon see, rotors. And these mother circuits or rotors can then act as a focus to actually develop further multiple little wavelets that cause atrial fibrillation to occur. So these rotors are actually little areas of self-propagating spindle or scroll-shaped areas of reentry that occur under the right conditions when an atrial wavefront encounters an anatomical functional obstruction. And what can happen is that the wavefront encounters this area and then breaks into these extremely stable reentrant areas. There are techniques that can actually map these areas, and we can generate maps known as dominant frequency maps that look at these areas to help us locate rotors. Now, as we can see, for example, in this image here, the areas of green are areas where there are areas of high dominant frequency regions. And these correspond actually fairly well to the pulmonary veins as well, and suggesting then that there is some significant overlap between these areas of stable reentry as well as areas which we look for when looking for pulmonary vein triggers. This is an interesting study that looked at how rotor patterns varied from individuals as they progressed from paroxysmal to permanent. And as we can see here in paroxysmal patients, these areas of rotor activity are largely clustered around areas around the pulmonary veins. Again, suggesting that when we are performing procedures of pulmonary vein isolation procedures, we are targeting not just pulmonary vein triggers, but potentially also these rotors as well. Whereas individuals with more permanent atrial fibrillation, the dispersion of rotors is a lot more varied, thus suggesting then that potentially different techniques are required for individuals with more persistent or permanent atrial fibrillation. So now that we have a relative grasp as to why atrial fibrillation may occur, we can then tackle then different techniques for atrial fibrillation itself. Atrial fibrillation has evolved, the ablation of atrial fibrillation itself has evolved quite dramatically over the last couple of decades. And as we can see, not only has procedural time decreased, as the years have gone by, but the success rate has also increased with a inverse relationship as well to the complication rate. And thus we have come extremely far to our initial procedures that were done at the infancy of atrial fibrillation ablation. In fact, the complication rates at this point have come down. Previously, complication rates were quoted approximately 4 to 5%, but the most recent systematic review of complication rates has suggested this has dropped to approximately the range of 2 to 3%, with vascular complications being the majority of these problems, account for 1.4% of complications, followed by tamponade, strokes and TIAs, pulmonary vein stenoses, phrenic nerve injury, atrioesophageal fistulae, and thankfully, extremely uncommonly, mortality. One of the initial procedures that were done to ablate atrial fibrillation was that of the segmental pulmonary vein isolation. And as we have seen earlier, a large number of individuals with atrial fibrillation have triggers within the pulmonary vein, and thus initial techniques were to target these triggers, and in order to do so, areas of pulmonary vein firing were actually located by mapping and were actually ablated, and these were often ablated within the pulmonary veins themselves. By ablating so deep within the pulmonary veins, however, these procedures were largely limited by the development of complicating pulmonary vein stenosis. As well, because you could only target triggers that you could actually see, there were potentially other triggers that were not present at the time that could be missed, and thus these individuals also had recurrences due to other foci that were missed. In order to perform these procedures, multipolar spiral catheters are placed within the ostia of each pulmonary vein, and pulmonary vein potentials are then identified either during sinus rhythm or during atrial pacing. To the left here, for example, we actually see an example of what can be seen with one of these spiral catheters within the vein itself. So this is a spiral catheter within the left superior pulmonic vein, or pulmonary vein. And what we can actually see here is an actual overlapping of far field atrial as well as PV potentials, pulmonic vein or pulmonary vein potentials themselves. What can be done in order to separate these two entities is to either pace from different sites. So you can pace, for example, either within the left atrial appendage, distal coronary sinus, or the right atrium to see if some separation can be achieved. Or alternatively, one can also enter atrial extra stimuli. And by either pacing from these different sites or pacing with extra stimuli, one can actually separate the far field atrial electrograms with the pulmonary vein potentials. Again, as noted earlier, for this technique, ablation is targeted at the area outside the ostium with the earliest pulmonary vein electrograms in order to achieve elimination of these pulmonic or pulmonary vein potentials. This here is an example of one such ablation, for example, where pre-ablation one can clearly see the pulmonary vein potentials, but post-ablation, after targeting these, we see successful isolation of this vein and what is known as entrance block, in that there is no further ability, in this vein at least, for the atrium to actually conduct within the pulmonary vein sleeve itself. Aside from targeting triggers, there have been a number of techniques as well that have strived to target the actual atrial substrate itself. And even before catheter ablation was performed, there were a number of surgical techniques that sought to ablate or tackle atrial fibrillation. And these were largely based upon the multiple wavelet hypothesis. Again, this was a hypothesis that presupposed that a large enough atrial mass was required to sustain atrial fibrillation. And thus, by debulking the atrium or compartmentalizing the atrium into smaller and smaller compartments, one could then hope to potentially eradicate atrial fibrillation. And so originally, surgically what could be done was a procedure known as the Cox-Maze procedure. And this was a technique where surgeons would in fact cut the atrium into separate components and then re-suture them back together again. And this was shown to be relatively successful in terminating and controlling atrial fibrillation in a number of individuals. And thus initially a lot of atrial fibrillation techniques were also based upon this and sought to actually replicate these Cox-Maze lines with linear ablation lines as well. The ultimate or the final progression of these linear procedures was the development of the wide antral circumferential atrial ablation, which is quite a mouthful to say, and so is often contracted to either WACA or LACA, which is left atrial circumferential ablation. And these are procedures where circumferential lesions are drawn around or ablated around ipsilateral pulmonary veins. And of course, this requires 3D anatomical, electroanatomical mapping in order to facilitate these procedures. And the endpoint for these procedures initially was the reduction in electrograms within the veins themselves without necessarily proving isolation of the veins. Following the ablation of these encircling sets, at times other lines would also be drawn. So an atrial roof line could be drawn adjoining the superior aspect of these two encircling lesion sets, or perhaps even a mitral annulus line, or mitral isthmus line, connecting the left side encircling veins to the mitral annulus itself. And this was really done to provide a catheter-based analog to the maze procedure itself. In general, these lines have been shown to actually help not only with paroxysmal atrial fibrillation, may also help with more persistent and permanent forms of atrial fibrillation. However, initial studies have shown that the production of these lines, including things like the roof line and the mitral isthmus line, can help to promote macro-entrant atrial tachycardia in the long term. This is an example of a set of lesions done with a wide antral circumferential atrial ablation procedure. We're looking here at a 3D electroanatomical map of the left atrium from behind. So this is a posterior anterior view, looking at the posterior aspect of the left atrium, with the 4 veins sticking out here. And again, the sets are essentially encircling the veins themselves. So unlike other techniques that aim for isolation of the pulmonary veins, this is strictly an anatomic strategy, looking for reduction of potentials in the lesion set itself. There is really no identification of pulmonary vein potentials, and thus you can actually get away without a spiral catheter in this procedure, and a single catheter is really all that is required. As noted earlier, other lines can be drawn, so a roof line can be drawn as well as a mitral isthmus line, and these further help to debulk the atrium even further, and may also help to eliminate other foci or potentially rotors. As we noted earlier, rotors can occur at different sites of the atrium, and some of them may actually occur in the area of the roof line, for example, and may be actually eliminated by ablation here. In addition, the ligament of Marshall, which may also have triggers, can also be ablated not only during the encircling lesion set, but also when ablating the mitral annular line. Also, as touched upon earlier, unfortunately, if these lines are not complete, then they actually encourage slow conduction across them and may then cause the development of macro-entrant atrial flutters or atrial tachycardias. Yet another technique that has been looked at to tackle the problem of the atrium as a substrate for atrial fibrillation has been the ablation of what are known as complex fractionated electrograms, or CFAEs. And these are electrograms within the left atrium that are believed to represent sites where wave fronts in the atrium either split or collide. And studies have shown that if one is able to ablate a sufficient number of these sites, then the atrium may not then be able to sustain atrial fibrillation in certain cases. This is an example of what these CFAEs look like. So they're defined as either areas of fractionation in the left atrial electrogram that have a continuous perturbation of the baseline or have a very, very short cycle length, as we can see here. Whereas the left atrium, for example, or the left atrial pinch sometimes can look very stable. We can see extreme fractionation of the baseline in areas like the left atrial septum, and extremely fast cycle lengths in areas such as the left atrial roof. Using proprietary analysis software that come hand in hand with electroanatomical mapping systems, one can then actually tag these areas of CFAE activity and then proceed to ablate them. So in this map taken here, for example, areas of red were areas that were shown to have significant CFAE activity in this individual. And as we have seen earlier, these CFAEs can be fairly extensive and can involve large areas of not only the septum, but also the roof and the posterior wall. There's also, as we can see here, significant overlap in the areas where CFAE ablation is performed on top of where a wide antral circumferential ablation is performed as well. So we can imagine that, in fact, encircling lesions around these veins here may also tackle a significant amount of this CFAE mass as well. At the present time, then, the technique for catheter ablation that is heavily promoted by the guidelines is one that attempts to tackle all of these potential strategies all at once, and that is the use of a wide antral circumferential ablation lesion set around the pulmonary veins with the goal of actually achieving pulmonary vein isolation. So by doing this, we actually hit on a number of these potential pathophysiologic mechanisms of atrial fibrillation all at once. Not only then do we actually achieve isolation of pulmonary veins and thus eliminate potential pulmonary vein triggers of atrial fibrillation, but by drawing large lesion sets around these veins, we can also then modify the substrate by debulking the left atrium itself. In addition, we may also eliminate certain CFAEs within here and rotors, as we will soon see. And we may also then burn areas that correspond with ganglionated plexi that lie around the veins themselves, and also help to achieve some modification of the autonomic nerve system as well. So thus, by performing this simple lesion set, we may actually be able to tackle multiple propagating and triggering factors for atrial fibrillation all at once. And studies have indeed shown that this is a fairly robust means of ablating atrial fibrillation. This was a meta-analysis that was published actually this year that looked at the use of a wide antral circumferential ablation targeting for pulmonary vein isolation versus a segmental osteopulmonary vein isolation procedure itself. So actually drawing these large lesion sets around the pulmonary veins and achieving all those goals that we talked about earlier versus just achieving pulmonary vein isolation itself. And as we can see here, in totality, when you look at all these studies, the wide antral circumferential ablation procedures did much better than segmental selective osteopulmonary vein isolation itself. In individuals who have more persistent or long-lasting atrial fibrillation, one may have to do a little bit more than just what we just talked about, though. As you saw earlier, there's probably more of a role that is played by the atrial substrate itself as opposed to just triggers. And thus, once a wide antral circumferential ablation is performed and the pulmonary veins are isolated, one can then proceed to a more of a stepwise approach to achieve treating this, especially if atrial fibrillation persists. So once that has been performed, if atrial fibrillation persists, individuals may perform CFAE ablation or linear ablation, so a roofline or a mitral isthmus line as noted earlier. I'm going to briefly talk about different energy delivery systems in atrial fibrillation at this point in time. We're largely familiar with radiofrequency energy, which is a means of delivering current generated by radio waves. And this energy is then delivered into the tissue and produces heating of the tissue due to a resistive method. The greatest current density delivered by the actual catheter is at the catheter tip, and thus the greatest amount of heat delivery is at that area too. Radiofrequency energy produces immediate change in the myocardium, resulting in denaturation of proteins due to the heating. And one can actually see acutely the development of fibrin at the area as well as char and thrombus. The immediate lesion set shows a central region of desiccation with surrounding hemorrhagic tissue that eventually evolves as healing occurs. There are potential challenges using radiofrequency ablation and atrial fibrillation ablation. For one, this is a point-by-point ablation strategy where the catheter is basically moved from each area of interest to try to create a homogeneous, contiguous line of ablation. Cardiac contractions makes positioning of the catheter sometimes difficult with regards to stability. The catheter force itself may vary with the position of the catheter in the heart itself. And simply speaking, the use of the point-by-point ablation and achieving these contiguous lesions may also be technically challenging. Cryoablation is an alternative strategy that can be used, and instead of heating the tissue, it achieves the same endpoint by actually removing heat from the tissue itself. The tissue is cooled to areas of less than minus 75 degrees Celsius, and as a result, tissue damage can occur at that site. Tissue damage can occur by direct ice crystal formation into the cells, creating both intra and extracellular damage, and thus resulting in cell death, or you can also get vasoconstriction of the surrounding area due to the cooling, thus resulting in first necrosis and then subsequent hyperemia due to rewarming, thus resulting in further damage to the tissue itself as well. I'm going to skip over this slide. So currently, a technique that has been used quite frequently in ablating atrial fibrillation is the use of the cryoballoon. And this is basically a balloon that is designed to wedge into the pulmonary veins and deliver cryoablation to the antrum of the pulmonary veins themselves. And the technique is essentially the delivery of the cryoballoon into the targeted vein, the inflation of the balloon itself. Once a sufficient occlusion has been achieved, then the balloon itself is cooled, and ablation is then delivered to the vein of interest. Following this, the veins themselves are actually reassessed. The cryoballoon has been suggested to help with atrial fibrillation ablation in a few different ways. Procedural time, for example, is reduced dramatically, not only in terms of the actual total duration of the procedure itself, but also in the fluoroscopic time required for the procedure. In addition, it is a technique that is associated with a much easier learning curve, and so it is much easier to actually master, or at least perfect, well, at least become quite skilled at the use of cryoballoon in achieving successful atrial fibrillation ablation versus that of point-by-point radiofrequency ablation. In addition, there is fairly equivalent efficacy in the endpoints when it comes to cryoballoon ablation versus radiofrequency ablation. And this is the reason then why cryoablation has begun to take fairly good traction in a number of centers. Now, atrial fibrillation and the ablation of atrial fibrillation continues to be a work in progress, and a number of further developments are continuing at this point in time in order to help perfect our management of this condition. For one, we know that atrial fibrillation helps individuals with AF in a number of ways. Studies have shown that ablation of atrial fibrillation results in improvement in quality of life in a number of individuals. In addition, there is suggestion that there may also be long-term benefits with regards to cardiovascular outcomes in individuals with atrial fibrillation ablation itself as well. This, for example, is one large retrospective study that looked at about 1,200 patients with atrial fibrillations from the United Kingdom and Australia. And this suggested that the ablation of AF was able to reduce not only the risk of stroke, but also potentially the risk of death in these individuals to that of the general population. So these are all results that are fairly positive and fairly promising. However, all these studies have been retrospective, and so these are studies that are somewhat flawed and and do not hold the same weight and gravity as prospective randomized controlled trials. So one thing that is currently in progress right now is a large prospective randomized controlled trial known as the Anatomical, which is hopefully going to be able to establish once and for all whether or not atrial fibrillation ablation has any long-term outcome benefits. And the big outcome that is being looked at here is mortality itself. So this is a study that we're all waiting for with bated breath. There are a number of other developments that are also occurring in atrial fibrillation ablation when it comes to tools that we are using. So as we noted earlier, point-by-point radiofrequency ablation is challenging because of the difficulty in achieving contiguous lesion sets around veins. But what has been developed, or is in the process of being developed right now, are single-shot multipolar radiofrequency catheters. And these are catheters that are shaped almost either in a spiral or an arc of a spiral that can be then positioned around the veins and actually achieve ablation along an arc as opposed to a single point at one time. And these catheters are actually extremely versatile in that they can not only be used to actually ablate, but they can also be used to create geometry, as well as be used to actually map for pulmonary vein potentials as well. So we can also not only reduce the procedural time when it comes to the actual ablation procedure itself, but also can reduce the need of multiple transeptal punctures and the need for multiple catheters in the left atrium as well. Another technique that is being developed at this point in time as well are improvements in actually mapping the substrate of atrial fibrillation. So as you noted earlier, rotors are one potential hypothesis as to why atrial fibrillation propagates in individuals with persistent or permanent atrial fibrillation. And there are techniques out there that attempt to actually map these rotors in real time. And what we can see in some of these areas is that we can actually then see how these stable reentrant circuits actually rotate within the left atrium itself. And studies have suggested then that ablation within these sites, these rotor sites, can actually, in some individuals, achieve resolution of the atrial fibrillation, termination of atrial fibrillation, and resumption of normal sized rhythm in certain individuals without significant ablations around, for example, things like the pulmonary veins. This study, which is the confirmed study, for example, looked at individuals at one center that underwent rotor ablation and showed that ablation of these rotors can terminate atrial fibrillation in 86% of individuals in atrial fibrillation using as little as 4 minutes of radiofrequency ablation. And these are individuals with persistent or permanent atrial fibrillation. And at a median of almost a year, the majority of these individuals were actually free of atrial fib versus those who underwent conventional pulmonary vein isolation. Now, at this point, while these results are very promising, the replication of the results are still pending with larger multi-center trials. So in summary then, we have gone through a whirlwind tour of the pathophysiology of atrial fib and why we do atrial fibrillation ablation. And hopefully by the end of this talk, we have now developed a great understanding of the pathophysiology of AFib, and we understand that this understanding continues to progress. And the actual pathophysiology itself can encompass a number of different factors, including focal triggers, a suitable atrial substrate, as well as reentrant rotor circuits. Atrial fibrillation ablation techniques have targeted each of these potential causes, and thus we have the multitude of different atrial fibrillation ablation techniques that are available to us today. The standard technique, as we have seen, however, remains the wide antral circumferential ablation technique with pulmonary vein isolation as its endpoint. At the present time, future ablation tools and techniques continue to be developed and are quite promising and should be available on the appreciable horizon. So I'd like to thank you for your attention, and hopefully at this point in time I'll be able to field any questions that are out there. So I guess if there are any questions, I guess people can enter them into the chat box. So I have a question here, can frank nerve palsy occur with radiofrequency ablation? And that's a good question. At the present time, frank nerve palsy is conventionally attributed with cryoballoon ablation, and that is just something that has been noted more frequently with that technique versus radiofrequency ablation itself. That is not to say that radiofrequency ablation itself cannot cause frank nerve palsy, but for whatever reason, the actual site where cryoablation is actually delivered with the cryoballoon appears to be more prone to encouraging frank nerve palsy. But as we've seen, the actual frank nerve itself runs in very close proximity to the right superior pulmonary vein, and thus if one delivers a significant amount of radiofrequency energy to that area too, it is not unforeseeable that injury to the phrenic nerve can occur there. In particular, in certain individuals where there may be other foci, for example, foci up in the SVC that individuals may want to ablate, then one has to take excessive care there because ablation within the SVC itself may also result in injury to the phrenic nerve. And so that is one area where you can actually see significant phrenic nerve injury with radiofrequency ablation. So another question here is, if radiofrequency causes charring, wouldn't cryo be preferable? And yes, that is one of the reasons why individuals have, certain companies, for example, have pushed for cryoablation to be the mainstay for ablation. And it is true that if you actually look at the lesions produced by cryoablation, they're often much neater from a pathologic standpoint. There is less charring. There is the lack of thrombus formation. So these are all putative advantages of cryoablation versus standard radiofrequency ablation. As to whether or not they actually result in significant differences, for example, in thromboembolism risk and things like that, at the present time, the actual difference is not significantly appreciable. And so it is something that is hypothetically and theoretically an advantage, but is not necessarily seen clinically to be a significant difference. So another question I have here is, do centers vary across Canada with regards to what procedures are offered? And the answer to that is definitely true, and it's not just across Canada, but even across North America itself. Different centers at this point in time do seem to have individuals who are proponents of different procedures. And I've been at centers, for example, where there are actually very differing beliefs with regards to the pathophysiology of atrial fib and what should be performed. If you actually read the consensus statement that has been put out by the HRS, for example, even amongst the expert panel itself, not everyone, for example, performs atrial fibrillation the same way. And that there are certain subsets of individuals, for example, who still do not seek pulmonary vein isolation, who use a single catheter in the left atrium, and individuals, for example, who will move from a WACA to then CFAE ablation and not linear ablations versus those who perform linear ablations but not CFAE. And so there's quite a bit of heterogeneity with regards to what is being done out there. And of course, each site and each center may then offer different success rates for their procedures. Similarly, not every center, for example, will provide both RF ablation as well as cryoballoon ablation for atrial fib as well. So there is some heterogeneity there as well. So I have another question here. How long do you anticoagulate patients post-ablation? And that's a good question as well. It really depends, first and foremost, as to what their underlying risk of stroke is. If their risk of stroke is, I think just to back things up a little bit, I think one of the things we have to recognize is that in general, an atrial fibrillation ablation procedure is or should not be seen at the present time to be a reason to come off of anticoagulation. So if an individual, for example, requires anticoagulation at baseline without an atrial fibrillation ablation, an individual, for example, who has a sufficient CHADS-2 score and sufficient risk for a thromboembolic event, and who are normally recommended to be on an anticoagulant, these individuals should remain an anticoagulant post-procedure indefinitely. There are certain centers in the United States that will look very closely, for example, to see if there's any recurrence of atrial fib. And individuals who don't have any recurrences, some centers actually will propose discontinuing anticoagulation therapy. And at these centers, at least, there is suggestion that perhaps the stroke risk is actually relatively low in these individuals. However, at the present time, the guidelines will still recommend that anticoagulation would still be continuing in these individuals regardless of what their burden of atrial fibrillation is afterwards. And this is probably a practically wise thing to do, especially given our uncertainty with regards to the success of atrial fibrillation procedure in some of these individuals. Individuals who do not necessarily need to be an anticoagulant post-procedure, then the actual duration post-procedure can vary. I personally keep people on anticoagulation for at least a month, and then potentially discontinue afterwards, whereas I do know some of my colleagues will keep individuals on for up to 3 months post-procedure. All right, those are good questions. Are there any other questions out there?
So if there's no more questions, again, I want to thank Dr. Khoo, again, Clarence, for your excellent talk tonight. Some really good questions as well in response to your presentation. Before people leave, I just want to remind everyone that your presentation will be available and posted on the web, and there will be opportunities to ask additional questions. As well, I just want to remind everyone that the Canadian Heart Rhythm Society annual meeting is in Montebello in September, so keep the September 12th and 14th dates in your day planners, and we'd love to have everyone attend. And also another reminder that the deadline for submission for presentation proposals for the Allied Health Professional Workshop at CCC is on May 15th, and I look forward to seeing your submissions. And if you've got an interesting case study, some of you I see online have presented in the past, and we'd love to hear from you. It's a great opportunity to network and share. And again, Clarence, thank you so much, and thanks for the attendance tonight.
Thanks for having me.